We'll make this fairly informal, and usually I want to give a talk I have, 75 slides. I thought, well, I'm going to do it different tonight, so that we can maybe have more involvement and have everyone's participation. So, Dave, I wondered if I'd be able to put this on your website. This is our website for urology.com. And the reason I'm mentioning it is that there is a magazine, maybe some of you might get, that's sent out to about 50,000 men around the country with prostate cancer. It's called Prostate Advocates for Advanced Cancer Treatments, PAACT. And this is the issue that just came out. And there's an article in here that's on our website. So anyone who wants to read it, they can go on the website. And the article is, "A urologist with newly diagnosed prostate cancer. Welcome to my journey." And that urologist is me, believe it or not. Yeah. So when we're talking about prostate cancer, new diagnosis, treatment, and complications of that treatment, I have sort of a unique perspective in that I've been seeing patients with these problems for 40 years, and also 6 months ago I had a radical prostatectomy myself. Okay, so I'm probably the first speaker that's ever told you that. What's that? I am, yeah. Also, you heard about this 2-day lecture at the Prostate Cancer Conference, and I've actually spoken at that a number of times. There's usually a couple thousand men that show up for that, and it's fantastic. Really, really worthwhile. So if you want more information or just want to interact with people, I would highly recommend it. It's definitely worth attending. So, Dave, you may put that on the website, and I'll give him this magazine as well, so if he wants to put the title of the article on there, you can. Okay. So today we're going to talk about quality of life issues with prostate cancer treatment. And one of the main things that I deal with all the time is bladder control problems in men that have been treated for prostate cancer. Okay? Does this top come off easily, or is it glued on there? I can take out a kidney, but I can't do a magic marker. Okay, there we go. So, I just came back from Pebble Beach. There's a couple of my friends and patients here, and I drove my car up to Pebble Beach, and my license plate is this. I make you drive. That's my license plate. Okay. So, I get a lot of women that follow me around the grocery store asking for my card and that kind of stuff. So, anyway, it's amazing how common it is that people have bladder control problems. It's thought that up to 30% of women have bladder control issues sometimes during their life. About 20% of men, and men that have been treated for prostate cancer, about 3 to 5% of men will have some major bladder control problems afterwards. And the problem with what we call incontinence or loss of bladder control is that it really affects quality of life. Where men have to wear diapers, they're embarrassed, they have access, they can't carry on their normal activities. Clearly it affects sexual function. But the good news about it is that it almost always is treatable. Okay? There are various causes for leakage problems after men are treated for prostate cancer. And that treatment could be surgery to remove the prostate, or it could be radiation, or it could be a combination of both. All of these treatments can have a negative effect on bladder control. So when I see a man that has bladder control issues, we look at basically 3 different causes of why that happens. First cause is called overactive bladder, or OAB. Okay? And what that means is that normally, when the bladder fills, there should be very little change in pressure as the bladder fills. And most men can hold around 12, 15 ounces in the bladder. You feel the urge to go after 3 or 4 hours, or whatever it is, you can go. So, in men that have overactive bladder, instead of having a nice low pressure filling, they have spasms as we fill the bladder. And with each of these spasms, the urge gets stronger and stronger. Until I said, I can't hold it anymore. I got to rush to get to the bathroom, or I have to wear a depend or something like that, because when the urge hits, I can't get there in time, and it just leaks. And And this frequently can be caused by nerve damage to the bladder as a result of the radical prostatectomy or from changes in the bladder wall related to radiation therapy. Okay? Very common, overactive bladder. The second cause for men leaking after treatment for prostate cancer is that they can have what we call stress incontinence. And what that means is that when they cough or sneeze or laugh, you lose urine. Okay? And it's not stress like I'm under stress, it means a stressful event. And the reason that can happen, particularly after prostate surgery, is that this is the bladder, here's the prostate, and right in front of the prostate is the bowel muscle, what we call sphincter. Okay? So when someone has surgery, like I did 6 months ago to take out your prostate, if there's damage to the bowel muscle at the time of surgery, then you can have trouble with leakage of urine afterwards. Okay? Leaking when you cough, sneeze, laugh, change position, and that sort of thing. And again, that can be various grades. It can be very mild, where somebody just has to wear Kleenex in their underwear, or it could be like a man that I saw today that has to wear 60 pens a day, and every time he stands up, the urine just runs out, because his bowel muscle damage is very, very severe. Okay. But the good news is there's treatment available for this, and we'll talk about that. So we talked about overactive bladder, talked about stress incontinence, and the third cause is a combination of both, where men have both an overactive bladder and stress incontinence. And that makes it a little complicated, because we have to sort of go in a stepwise fashion and try to control the bladder problem first. And once we get rid of the spasms, then we can treat the stress incontinence with a weak bowel muscle. And the way we determine what's going on as far as these different causes for bladder control issues, we do special bladder function tests in the office. It's called urodynamics. And basically it's a test that takes about a half an hour. It involves putting a small tube in the penis. We fill the bladder with fluid and check the nerve function of the bladder and check the bowel muscle. And by the end of that test, we can tell the man exactly what the cause is and why is this happening. That test is very, very important, because if someone goes to a doctor and says, oh, you're leaking, we're going to do an operation. And you don't do these tests, you're going to be wrong probably 60-70% of the time. And then somebody has an operation, and they say it didn't work, the results were horrible. Okay, so having that proper evaluation for treatment is really, really important. So once we determine the cause of the bladder control problem, which again is a huge quality of life issue, we talk about what kind of treatment is available. So when somebody has the overactive bladder with the spasms in the bladder, there are a couple different options. The first option that we can offer is a program that we do called biofeedback. And what that means is that we have a special nurse that works in our office that treats 10 patients every day. And what she does is she hooks the man up to a special computer and teaches them how to retrain the nerves and the muscles that control the bladder to get rid of those spasms associated with the overactive bladder. And what it involves is coming once a week for about 8 weeks. Each treatment is about an hour. And it's paid for by Medicare and other insurances because it works. And overall, it's about 70% effective, especially for men that have more mild to moderate leakage problems. Somebody's wearing a couple of small pads a day, they have a very, very good chance of improving with this biofeedback program. There's no downside to doing it. It's not dangerous, it's not painful, it doesn't involve any tubes in the penis or anything like that. The second choice, when somebody has overactive bladder, are pills. And these pills that you see advertised a lot on TV are to relax the bladder, to get rid of the spasms. And you see ads, I see them all the time, particularly for medicine called Mirametric, other medicines that have been around for a long time, like Vesicare, Ditropan, similar medications to that. With these pills, if they work, you pretty much have to stay on the pills indefinitely. And somebody takes them and they stop the pills, and usually the leakage will come back. side effects. The Myrbetriq can make your blood pressure go up, and all the other pills like Vesicare, Ditropan, so forth, cause a lot of dry mouth, constipation, blurry vision, those sorts of things. So many times patients will come back and they say, the medicine is helping me, but I can't stand the side effects. I'm so dry, I can't even talk. So the newer medications have fewer side effects, but still, they have some, and they're expensive. A lot of health plans don't cover the medication. I had a patient today that told me it costs her $300 a month for these pills. Okay. Very expensive. For some people anyway, depending on their coverage. When the pills don't work, or somebody says that, you know, I'm having too many side effects, there's also an option called InterStim. And what this is, it's like a bladder pacemaker device. And what we can do is we put two little wires in the back. There's the nerve that controls the bladder, and it sends a signal to the nerves to tell the bladder to relax, to get rid of the spasms. And the good thing about this is that we can do a test in the office to see if it works. And if it does work, then the procedure to put this bladder pacemaker in is about a 30-minute deal. And again, it's about 70–80% effective. Okay. There's also the option of Botox. Everyone knows about Botox for cosmetic reasons, women getting injected in their face to get rid of wrinkles, that sort of thing. But it also works in the bladder. And what we do is, with a special scope, we actually inject the Botox into the wall of the bladder, and that relaxes the nerves and gets rid of the spasms of the bladder. Okay? The thing about the Botox is that it usually has to be repeated about every 6 months, and sometimes it can relax the bladder so much that the man can't urinate afterwards. That can happen about 10% of the time. So if that happens, then the person has to actually catheterize themselves a couple times a day to empty the bladder. Okay. So those are the kinds of treatments that we talk about when somebody has overactive bladder. And when we see 100 men that have bladder leakage problems after prostate surgery, probably about 55 out of the 100 have overactive bladder. So it's very, very common. So, the second common cause we talk about is stress incontinence, where that valve muscle is damaged. And again, when somebody has stress incontinence, that biofeedback program that we talked about can help a lot. Where you come once a week for 8 weeks, and special nurse teaches you how to make the valve muscle stronger. And during that session, they also send some electrical signal to the muscle to help make the muscle stronger as well. It's called electrical stimulation. When the biofeedback doesn't work and somebody's having significant leakage when they cough or sneeze or laugh, then we talk about surgical options. And there is something called a male sling, S-L-I-N-G. I don't know if any of you ever heard of this procedure, but what it is, it's a procedure where a piece of mesh is put underneath the urethra, underneath the tube that carries the urine out, to act like a backstop, put pressure on the urethra, near where the valve muscle is, to help it close better. Okay? And this was something that probably 5 to 6 years ago, everyone was very enthusiastic about it. But when we look at the long-term results with it, only about a third of men are happy with the results and have significant improvement in their control. If someone has more severe leakage, it doesn't work very well. If someone's had radiation, it doesn't work. If they had previous surgery in that area, it doesn't work. So I've seen a lot of men that, oh, I had this male sling, and I was a little bit better for a few months, and now I'm right back where I started. So it's not something that really has been a big breakthrough as far as treating men with stress incontinence. What has been a big breakthrough is something called the artificial urinary sphincter, or AUS. This is something that's been around for about 20 years, but has gradually improved over many years, so that now, overall, with the artificial sphincter, about 85% of men are very, very helpful, or very satisfied with the results. So it's an operation that takes about 45 minutes, usually in the hospital overnight. car holds the fluid. And that goes up here underneath the muscles. It has a cuff that goes around the urethra. That closes the urethra and allows you to be dry. So it replaces that damaged sphincter or bowel muscle so you don't leak. And it has a pump that goes inside the scrotum. Again, everything is inside, underneath the skin. In front of, just like an extra testicle or in front of the testicle. So the way that it works is when the man wants to urinate, he squeezes the pump. Again, it's inside the scrotum 2 or 3 times. That opens the cuff and allows you to urinate. Then automatically in about 3 minutes or so, the cuff closes by itself. Okay. So it's a huge advance in how we treat men that have sphincter damage after radical prostatectomy. And there are some risks with it, a small risk of infection. Sometimes after 8 or 10 years, it can be mechanical problems where something breaks and then we have to reoperate to fix it. But it, for a lot of men, it makes a huge difference in their quality of life. So I want to pass this around. The last time I gave a talk here, I passed something like this around and somebody took it home. I don't know what they're going to do with it, but make sure I get it back, please. Okay? So, that's the artificial sphincter. And then we talked about the issue about where somebody has both combined overactive bladder and stress incontinence. And that is, again, a more complicated problem. And those bladder function tests help us determine what the exact problem is. So what we do is we treat this overactive bladder first and get rid of the bladder spasms. Once that's under control, the man says, listen, I don't have that urgency. I don't have to rush to get to the bathroom anymore. But still, every time I cough or sneeze or laugh or lift something heavy, I leak urine, then we'll talk about treating the stress incontinence. Okay? So very commonly that we might have medications and then the artificial sphincter or some other combination of that. Okay? So before we switch gears and talk about sexual function, are there any questions I can answer about bladder control problems? We can also save them till the end, but if anyone has any pressing questions right now, we could address them. You want to use the microphone or just have me? Okay.
Hello. With the AUS, you started off mentioning that there's this little bladder, and does this end up containing urine, or is it as a reservoir?
Yeah, the reservoir is filled with sterile water at the time of surgery.
Okay.
So just like a radiator in your car holds the fluid, that holds the fluid that pressurizes the device and makes the cuff close.
Oh, so it's more of something that helps close the device.
Yes.
Okay, got it.
So as I mentioned, you have the urethra and then the bladder. So that cuff sits around the urethra, just like this. And the pressure in that balloon allows the cuff to close, allows the man to stay dry. And then when you squeeze the pump, the cuff opens, you can urinate normally, then automatically in about 3 minutes, the cuff closes by itself. And that closure of the cuff is because of the pressure in that little balloon. It's a pretty amazing device, and it works very well.
Where's the prostate in that picture?
Where's the prostate? Well, here it's gone, but if it were here, it would be behind this cuff. So the cuff is in front of the prostate gland. The picture that I drew earlier where the valve muscle is, the same area. Yes, sir, you want to pass the microphone?
Yeah, here. Yes. I was wondering, how do you install it? I mean,
How do we install it? Well, it's, like I said, a 45-minute operation. And what we do, I'm a horrible artist, but anyway, there's an incision behind the scrotum, between the scrotum and the rectum. And that's where the cuff goes, around the urethra. And then there's another incision up here on the abdominal wall in this area, and that's where the balloon goes, underneath the muscles. So everything is inside. Okay. When we put it in, we test it to make sure it's working well, and then we deactivate the device. We turn it off because it's too painful to squeeze a pump for a couple weeks. And once the pain is gone, we just turn the device on in the office, and usually everything goes very well at that point. Yeah. Other questions about bladder control? Yes, sir.
Just quickly, is that an outpatient or an inpatient?
Usually we keep people overnight, mainly for antibiotic treatment, because the biggest concern about the operation is there's about a 3% risk of infection. And if an infection occurs, the whole thing has to come out, and that's bad news. So we keep people overnight to give them strong antibiotics to minimize that risk of infection.
Thank you.
Okay. Other questions? Okay, well, we're going to go on to sexual function. Also known as ED, erectile dysfunction. Okay? When I was a Kaiser, we used to have a class for men that had erectile dysfunction. We used to say, how many impotent men could you squeeze in one room? So that was something that we did once a month, and we had about 75 or 100 men that would come. And the reason for that is a very common problem. It's thought that up to about 50% of men at some point in their life will have problems with erectile dysfunction. When someone has treatment for prostate cancer, that could also have a very negative effect on sexual function. And it could happen for two reasons. If this is, again, the prostate and the bladder, prostate, bladder, the nerves that carry the signal for the erection run right next to the prostate, very, very close. Okay? So if in the process of removing the prostate, those nerves are damaged, then the man's going to have issues with sexual dysfunction or erection problems after the surgery. The nerves are very small, but when the surgery is done now, it's done with generally a robot, and everything is magnified on a big screen. So the surgeon can usually see the nerves and hopefully preserve them during the surgery. These nerves can also be damaged with radiation therapy in the area as well. Sometimes, depending on where the cancer is in the prostate, if the cancer is very close to the nerves, in order to get the cancer out and have a clear margin, sometimes the nerves have to be sacrificed at the time of surgery, depending on where the cancer is located. But if possible, the technology exists now where the prostate can be removed and both those nerves can be preserved, and the man can still have pretty good sexual function afterwards. The other reason why men have ED after treatment with prostate cancer is problems with the blood vessels. In order for a strong erection to occur, the blood flow into the penis has to increase about 6 times normal. And these arteries are very, very small. They're about the size of the tip of a pen. So if those arteries get plugged, just like as men get older, they get blocked to the arteries in their heart, their legs, and elsewhere, then you can't get that blood flow going through there. And very commonly, men will tell me, you know, I get like a 30% erection, but it's not hard enough to really do anything. And a lot of that is because of blood flow issues. And again, somebody has radiation therapy, those vessels are very, very small. It's easy to damage the arteries. Okay. So, when we have a man that has erectile dysfunction, there's basically 3 choices. And again, the good news is that it's treatable. It's not something that you have to live with. Number 1 are the pills. The Viagra, the Cialis, Leach, all pills that, again, you see advertised all the time. But these pills work by opening those very small arteries and increasing the blood flow into the penis. A couple of issues with the pills in the past have been very expensive, sometimes $30 for one pill. But now there's a lot of these pills that are available in generic, where you can get a pill for like $2 or $3 instead of $30 like it used to be, which is a lot better. The pills open the blood vessels, but they're not specific just for those small blood vessels in the penis. So a lot of men, When they take these pills, they say they get a headache, they say they feel hot, they feel flushed, their face gets red. It's because of the pills opening those arteries all over the body. Okay? So sometimes the side effects are intolerable. Also, Viagra can affect a man's ability to see blue light for some reason. So pilots can't take it because if you land on the runway, there's blue lights along the runway. So when the pilots can check, they always tell them no Viagra, buddy. So at least not when you're flying. Otherwise, they might miss the runway. Okay? When the pills don't work, there's also something called injection therapy. And what that is, it's actually taking the medicine in a syringe with a small needle and actually injecting it into the penis, just like a diabetic gives themselves insulin. So those blood vessels run in two different chambers inside the penis. And so this needle goes right into that chamber where the blood vessel is, and it's injecting a medicine called prostaglandin. And what that does, it opens the arteries very, very widely. Okay? And so what we do, if a person is an appropriate candidate, we actually teach the man how to use the medicine in the office. And when they want to have sexual activity, they just give themselves a shot with this very small needle into the penis, and it's pretty reproducible as far as creating a very strong erection. One of the problems with it is sometimes the erection won't go down. Okay, and we tell everybody if it lasts longer than 3 or 4 hours, you got to go to the emergency room and then get another shot to make it go down. So that can be an issue sometimes. Okay. But some men use the injections and are very happy with it. Other men tell me, you know what, I don't like the idea of sticking a needle in my penis, or it's painful, or sometimes after repeatedly sticking a needle in it, some men will develop some scar tissue in the penis and like hard areas that they can feel. So it's not for everybody, but there are some men that are fairly happy with it. It's called injection therapy. So the third option is when the pills don't work, and somebody doesn't want injection therapy, or they don't like it, is something called a penile implant. Okay? And again, just like that artificial sphincter that I showed you, it's a hydraulic device, like I would pass around. This is the one that I lost last time I was here. So in a similar way, it has a reservoir that holds the fluid, except this one's a lot bigger than the softball-sized reservoir you saw in the other deal.
I got that.
Okay, thank you. And again, the reservoir, everything is inside. The reservoir goes here underneath the muscles, in the abdominal area, underneath the muscles. Just like the artificial sphincter, it has a pump that goes inside the scrotum. And that makes the device go up and down. So it's a very natural thing. You only have the erection when you want to. And these are the two cylinders that go in the penis to cause the erection. So again, inside the penis, there's two chambers that normally fill with blood. So these cylinders fit inside of the two chambers and allow the penis to become firm when a man wants to have sexual activity. These cylinders come in different sizes. We measure at the time of surgery. We put the size in that's best for that person. So again, it's very natural. So the way that it works is there's saline sterile fluid in the reservoir. So when a man wants to function, he squeezes the pump, and that moves the fluid from the reservoir into the cylinders and makes the penis hard. Okay. And then when you want to go down, you push the button, and it goes down. It moves the fluid from the reservoir, from the cylinders back into the reservoir. Okay. So it's very natural. You only have the erection when you want to. A lot of men are in a health club. They're walking around in the gym or in the shower room with this. Nobody can tell that you have this. So it's very, very. The overall patient and partner satisfaction with this is about 95%. So it's an operation done in the hospital. It takes about 45 minutes. And again, just like with the other procedure, we usually keep men in the hospital overnight, mainly just for antibiotic therapy. Okay? It's called inflatable penile prosthesis. Let me pass that over. So sometimes we have men that have combined problems with both stress incontinence, where they have the artificial valve, and erection problems, where they have the penile prosthesis. That means they have two pumps in the scrotum, one to urinate, one to have sex. So we just have to make sure they don't get confused, otherwise it creates a lot of problems at home. Okay? All right. So we talked about bladder function issues and incontinence. We talked about sexual function, why that erection problems happen after treatment for prostate cancer and treatment options. So what questions do we have? Yes, sir. You had a question?
Would you be having the same sensation?
Good question. Will you be having the same sensation with the wife? If somebody has sensation beforehand, they don't have it afterwards. So if a man tells me, I can feel normal sensation in my penis, I can have a sensation of orgasm, they don't have that afterwards. If somebody says, I have nerve damage because of radiation or whatever, and I don't feel anything, and I'm not able to have a sensation of climax or orgasm, then the device does not bring that back. All it does is give a firm penis to be able to have sexual activity.
In other words, that's for your spouse or your partner.
Well, that's a good question. He says, if you don't have a sensation of orgasm, is this just being done for the spouse? A lot of men tell me that they really miss having intimacy with their partner, with their wives. And if we can restore that, it really makes them feel much better with their relationship issue, makes them feel better with their relationship with their wife, and so forth. So that can be a very important aspect of it too. Okay. Other questions?
How long do these devices last?
Here.
They could be replaced after so
Other
long.
people can't hear.
Yeah.
So how long do you have before they have to be replaced, or do they have a?
They can have mechanical problems. At 10 years, 85% of men are still doing well with them, okay? And so what can happen is after a number of years, sometimes a tubing can crack or something like that, and then there's just sterile fluid in the device will leak out. It's not dangerous, it doesn't hurt anything. But I'll get a call, I'm trying to pump my device and nothing's happening. So that usually means just no fluid loss. And that's a matter of doing an operation, replacing the device. But at 10 years, 85% of guys are still doing well with it. Pretty good.
Yeah.
Yeah. It's been improved a lot over the last few years. Yes, sir.
Do you take these calls at midnight?
I have, believe it or not. Not that I want to, but
So
it's happened.
you mentioned that about 3 weeks before you could use the AUS, I guess,
Mhm.
before it was okay to actually use.
Yeah, as soon as the tenderness goes away on the pump.
So how long is there discomfort with the penile implant?
Usually about 4 to 6 weeks.
4 to 6 weeks.
Yeah, and the pain can be significant for like the first week or so. But after that, most men are like up and around. If somebody has a desk job, they can pretty much go back to work. But it's going to be a little bit sore for about a month or so.
And does that mean, people just wouldn't want to use it? And then after 6 weeks, then they would want to use it because it's not sore anymore?
Yeah, I mean, the limiting factor is, can the person squeeze a pump and not have pain? Because to transfer enough fluid, as I showed you, to make the penis erect, you got to squeeze the pump about 8 to 10 times. So if it's tender, then you just have to wait till that goes away. It's usually about a month or so.
How about tenderness in the penis?
Not so much. It's more around the pump and the scrotum. That's really the main location. Also, where we put the reservoir that holds the fluid up here in the abdomen. So there's a small incision there. So it's sort of like having a hernia repair. So that can be a little bit sore as well. It tells, and don't lift anything heavy for a couple weeks. Let that heal up. Yes, sir.
Going back to the surgery or the radiation that will destroy the nerves that for the sensation that get your thing high. What are the chances or the risk? I mean, what are the chances of the radiation compared to the operation of the nerves being damaged?
Well, that's a good question, and there haven't been really good studies on that. And part of the problem is that, prostate cancer is more common in older men. And a lot of older men, even before they know they have prostate cancer, might have some erection problems, where things aren't working that great to begin with. So that's why we know that after surgery, about 50% of men will have some erection problem, okay? Many of them were not that normal to begin with. So if you have a man 65, 70 years old that's going to have prostate cancer, treatment, whether it's radiation or surgery, if they have some pre-existing problems, certainly it's going to make it worse. And with radiation, we don't really know how common it occurs, but I would say it's probably at least as much as surgery, most likely. The thing about radiation is that the damage from the radiation goes on for many years. It's not just somebody gets radiation and then within 6 months the effects go away. It's ongoing damage that continues for many, many years. And it could be scarring or damage to the nerves. It could also be some damage to the bladder that causes the urgency and frequency that we talked about as well. So that's one of the down things about radiation therapy, is that it can go on for many years. And some patients that I've seen have had complications with the radiation where it damages the bladder wall, they get bleeding, they have to go to the bathroom very frequently because the bladder just can't expand because of the scar tissue. So I'm not saying radiation therapy is bad, but certainly there are complications, and somebody should not look at, I don't want to have surgery, I'll have radiation, I'm not going to get cut on. Either way, there's a significant risk of problems. And in that article that hopefully Dave will put on the website, we talk about putting that into the equation when you're trying to decide what kind of treatment you're going to have.
So, let me ask the question. In terms of radiation therapy, what percentage of the time do you have the side effect of radiation damage, okay, to the tissue?
Yeah, so the question is, how often do you have radiation damage to the tissue after treatment for prostate? Nobody really knows for sure because it's not been well studied over a period of many, many years. Because again, somebody may do well for a year or two, and then they start developing problems with bleeding, or rectal bleeding, or rectal pain, or incontinence, or erectile dysfunction. And also, there's many different forms of radiation therapy. It used to be that they used to just radiate the whole pelvic area, and then they went to a more focused radiation, supposedly only to the prostate. Many of you have heard about seeds, or maybe had seeds implanted in the prostate. It was thought that that was more localized and less chance for damage. And then there was proton therapy, which is again thought to be very, very specific. You're only treating the cancer, but really the bottom line is all these forms of radiation therapy can have major side effects. And,
So would you agree with this, that the risk of side effect of radiation therapy has at least something to do with the radiation doctor that you choose? Okay, some doctors have performed the therapy thousands of times. Other doctors have performed it hundreds of times. So you want to get somebody that's really experienced.
Absolutely. And I would say that's true for any kind of treatment, whether it's for radiation or someone's going to have surgery. You want someone that does it all the time and is really, really good at it. So that's very, very important. The other thing about radiation therapy, and this is, I talk about this in the article that I wrote, is whatever treatment you choose, I know there might be some people here that are newly diagnosed, whatever treatment you choose, that's a very, very important decision, because once you decide on treatment, you can't go back. And by that I mean, if somebody has prostate cancer and you decide to get radiation therapy, and then say 2 or 3 years later their PSA starts to go up, it's very difficult to go in and remove the prostate at that point. And if you do, because of the damage from the radiation, there's a very, very high chance that you're going to be severely incontinent and have leakage problems, maybe damage to the rectum during the surgery, certainly sexual dysfunction, and so forth. I've seen many patients that got radiation, and then their PSA starts to go out, and they go back for more radiation, I've even seen patients that have gone for cryotherapy after multiple radiations where the PSA goes up, and it's usually a disaster as far as bladder control is concerned. So,
I have a question here, doctor.
hey, Doug.
Leach, why don't you use me as an example for the radiation cystitis and what we've gone through?
Yeah, when I was talking about that, I was looking at you thinking about that. But, since Don brought that up, he's a very, not typical, but somebody that, had the radiation and then had damage to the bladder because of the radiation and had, multiple episodes of severe bleeding, even to the point of having to be getting a transfusion because he bled so much on the bladder after the radiation therapy. Luckily, we were able to get him plugged into some treatment, including hyperbaric oxygen over in Long Beach, where he'd go twice a week, Don, for like a couple months.
Every day if I wanted to.
Yeah, to go with the hyperbaric chamber to try to get more oxygen there and try to reverse the radiation damage. And thankfully, that helped him, I think, quite a bit. But it's ongoing damage. Yes, sir.
You guys want to give me the microphone? Oh, wait.
Testing, 1, 2, 3.
Okay. Just a comment. It's been, I had prostatectomy in '94 and radiation in '96, and it's only been recently, let's say 4 years ago, that I've really suffered with increased, with incontinence at all, and then increased. So, point is that you really don't know what's gonna, and there hasn't been a lot of studies done because there's 20 years before the problem happens. But the question that's my comment. My question is, why not do both procedures at once if you've got both problems?
Obviously, both procedures are.
Let's say AUS and this, like.
Oh, the U.S. like the penile prosthesis you're talking about?
Yeah. Well,
Yeah.
both. Yeah.
Yeah, we've done that sometimes. Yeah, we're manage both problems and it's called double implant. We can do that because it's only one anesthesia instead of two. It's only one recovery instead of two separate recoveries. So yeah, we certainly probably do that maybe like 5 to 10 times a year. Yeah.
Thank you.
Yeah.
I'd like to piggyback on one of the comments that the doctor made, and I think it's extremely important. And we have some people that were newly diagnosed in this meeting. And when you're told you have prostate cancer, your first thought is how do I get rid of it? And you want to get rid of it as fast as you can. And it really is important that you take your time, become informed about prostate cancer, and interview different doctors and then make your decision. I've had people that have come to me and they said, they had this therapy and they wish they had waited longer, to figure out what was really suitable for them. So, like the doctor says, once you make that decision and have that therapy, you can't reverse it 5 or 6 years later, and that may prevent you from having a therapy that you really need at that time.
The way that I thought about myself personally is that, my father had prostate cancer. I figured sooner or later I'm probably going to get it. So I watched my PSA and I watched it go up over a number of years. And when it got to about the mid-5 level, I said, well, I might as well get a biopsy. I'm sure it's going to be cancer there. So I was able to find it at a fairly early stage where it has a good chance of cure. And so to me, the best chance of cure, again, I'm mainly talking about the newly diagnosed guys here, if it's localized, is to remove the prostate and get the cancer out of your body. And then you're following your PSA, hopefully it goes to 0 and stays there. But just like this gentleman was saying, there's about a 20 to 30% chance that even though everything appears localized, that after 5 to 10 years, your PSA may start to creep up. And if that happens, it means there's prostate cancer cells somewhere in your body. And then you might have to get radiation therapy or some other types of therapy as well. But the concern that I had about radiation is that if you have radiation and then the PSA starts to go up, you're more or less stuck. You can't really remove the prostate at that time. all the time, and that it has good results. And this is not the kind of thing you want to go see somebody that does, you know, 1 a month. You want to see somebody that does a couple hundred a year, and that makes a huge difference.
Any other
Well,
questions?
we have a mug for you.
Oh, you
mug
do?
For your,
Good.
for your use in your car. Unfortunately, we had to back order, okay?
Okay.
But as soon as we get it, we will expedite it to your office, and we want to thank you for an excellent meeting here today.
So Dave will put the website address, with the article, there's other information there about prostate cancer on our website. I also put a bunch of cards here on the table, so if anyone has any questions or anything I can help you with, feel free to call, and I'd be glad to try to help you out in any way I can. Thank you.
Thank you, Doctor.
And he calls you back.
Do I call you back? I think so.
You call back.
Yeah, I do. Try my best. Another question?
Well, it's just for the team here. You recorded the presentation. Will that be available on the website or one way or another?
Ask me.
Oh,
Yeah.
So I have to do some processing, turn in the MP4, but right now I'm sort of stuck because we have a place on YouTube that our gentleman that was doing that for years is in rehabilitation. He can't get to his computer, and I need to figure out where this is. So I'm working on it. I know how to do it. I'll take this and upload it as soon as I got that place on YouTube to upload it to.
great.
Okay, thank you.
How would somebody find it on
Come
YouTube?
back and see us soon.